You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about coarctation of the aorta. We'll talk about the epidemiology, presentation, imaging features, and intervention. Let's start with the epidemiology. Coarctation of the aorta involves a shelf in the posterior lateral aorta wall opposite the ductus arteriosus. Coarctation of the aorta is more common in males than females at a ratio of 1.5 to 1. 60 to 80% of coarctation of the aorta has bicuspid aortic valve as well, but only 6% of bicuspid aortic valve has coarctation of the aorta as well. ASDs, VSDs, and patent ductus arteriosus are also common findings together with coarctation of the aorta, but not as common as bicuspid aortic valve is in coarctation of the aorta. The ventricular septal defect that is seen in coarctation of the aorta is inlet VSD, also known as AV canal VSD. Among Turner syndrome patients, 15 to 30% have bicuspid aortic valve and 7 to 18% have coarctation of the aorta. Only females are affected by Turner syndrome, whereas Noonan syndrome can occur in males or females. 80% of Noonan syndrome patients have congenital heart disease, and their congenital heart disease is pulmonic stenosis or hypertrophic cardiomyopathy. 30% of Turner syndrome patients have congenital heart disease, and their disease is either bicuspid aortic valve or coarctation of the aorta, or both. Presentation. Young patients with coarctation of the aorta are usually asymptomatic. Adults with coarctation of the aorta may present with headache, leg fatigue, and intermittent claudication. Simultaneous palpation of the upper and lower extremities in patients with coarctation will reveal diminished and delayed femoral pulses compared with the radial pulse. This finding is accentuated by exercise. Auscultation of coarctation of the aorta will reveal a mid-systolic murmur over the chest and back. There may be an ejection click and systolic murmur from a concomitant bicuspid aortic valve. However, a normal upper extremity, lower extremity blood pressure does not exclude coarctation of the aorta because the patient may have significant ascending to descending collaterals. Next up, we'll talk about the imaging. On echo of coarctation of the aorta, you should see accelerated flow across the aortic isthmus with an elevated peak velocity. You should also see diastolic forward flow in the abdominal aorta. CW Doppler on the coarctation in suprasternal notch view will show color flow acceleration on color Doppler and a high velocity jet on CW Doppler with persistent obstruction throughout the cardiac cycle. PW Doppler of the descending aorta in a patient with coarctation of the aorta will show delayed arterial upstroke due to the restricted orifice at the coarctation that it has to get through, systemic turbulence, and continued anterogate diastolic runoff because the volume is still trickling through the narrowed orifice even though it is diastole. Recall that the normal Doppler pattern in the abdominal aorta is a rapid arterial upstroke in systole and a brisk return to the Doppler baseline in early diastole, followed by a brief early diastolic flow reversal. The early diastolic Doppler flow reversal that is seen in normal hearts is not seen in coarctation of the aorta because it is overridden by the persistent diastolic runoff. In contrast, both severe aortic insufficiency and a large PDA would have a holodiastolic flow reversal, not forward flow in the abdominal aorta. Arterial flow from branches of the abdominal aorta will have a brisk systolic upstroke and downstroke in the arterial pulse, followed by low velocity continuous forward flow in the diastole into the low resistance GI circulation. TTE needs to be followed up by CMR or CT angiography, class 1 indication, which will show extensive rib notching arteries as well. Aortic coarctation patients should have repeat MRI or CT angiography of the aorta every 36 to 60 months, which is every 1.5 to 5 years. The most common site of coarctation in infants and children is juxtaductal, meaning the narrowing is opposite the insertion site of the ductus arteriosus. This is accompanied by a posterior infolding, or ledge, of thickened aortic wall media tissue. The typical neonatal presentation of severe coarctation is cardiovascular collapse when the patent ductus closes. Systemic hypertension and LV hypertrophy present later in childhood with coarctation. A significant peak-to-peak gradient across the coarctation is considered to be 20 millimeters of mercury, given that collateral flow can be extensive around a coarctation. Systemic arterial pressure will start to be lowered when the aortic lumen is narrowed by 50% in coarctation of the aorta. If you administer prostaglandin E and reopen the ductus arteriosus, the classic Doppler findings of coarctation in the abdominal aorta, meaning delayed arterial upstroke, prominent diastolic runoff, will disappear because pulsatile flow from the pulmonary artery bypasses the juxtaductal area of obstruction and provides the descending aorta with pulsatile flow. Now let's talk about intervention. Repair, which can be surgery or transcatheter, of coarctation of the aorta should be performed if there is any of a CoA gradient more than 20 millimeters of mercury, radiologic evidence of clinically significant collateral flow, systemic hypertension attributable to CoA, or heart failure attributable to CoA. What do the 2018 congenital heart guidelines say? Surgical repair or catheter-based stenting is recommended for adults with hypertension and significant native or recurrent coarctation of the aorta. That's a class 1 recommendation. How is significant coarctation defined? It could be upper extremity, lower extremity resting peak-to-peak gradient more than 20 millimeters of mercury, or Doppler systolic gradient more than 20 millimeters of mercury. It could be upper extremity, lower extremity gradient more than 10 millimeters of mercury, or mean Doppler gradient more than 10 millimeters of mercury, plus either decreased LV systolic function or aortic regurgitation. So if you either have decreased EF or AR, then they decrease the criteria from needing at least 20 millimeters of mercury to needing at least 10 millimeters of mercury in your gradient. Or upper extremity, lower extremity gradient of more than 10 millimeters of mercury, or mean Doppler gradient more than 10 millimeters of mercury with collateral flow. That is what they mean by significant coarctation. This should be coupled with anatomic evidence for coarctation of the aorta, typically defined by advanced imaging with CMR or CTA. The best evidence to proceed with intervention for CoA includes systemic hypertension, upper extremity, lower extremity blood pressure gradient, and echocardiography Doppler gradient as defined above, and anatomic evidence of CoA. Recent ESC guidelines use imaging and include stenosis more than 50% as an indication as well for intervention. MRI or cardiac CT are required because you need to precisely define the location of the CoA and guide the choice of intervention. Of the two transcatheter approaches, aortic stent versus balloon valvuloplasty, aortic stent placement for CoA is a preferred option because balloon angioplasty alone has a higher rate of intimal tears and aneurysm formation compared with stent placement. Therefore, balloon angioplasty is not preferred in coarctation of the aorta. In their own words of the guideline, they say, balloon angioplasty for adults with native and recurrent coarctation of the aorta may be considered if stent placement is not feasible and surgical intervention is not an option. Class 2B, so they don't really like that. They're reluctantly saying that. Post-repair of coarctation, the problems are persistent hypertension, unaddressed bicuspid aortic valve, ventricular dysfunction, re-coarctation, aortic aneurysm formation, subaortic stenosis, increased risk of endocarditis and endarteritis, and 10% of coarctation patients will also have a brain aneurysm. 1/3 of patients will have persistent hypertension after repair of the coarctation, especially if their repair occurred at an older age or if they had a higher blood pressure at the time of repair. 11% of repaired CoA patients will develop re-coarctation or aneurysm formation. Restenosis should be suspected if there's any of the following: an increase in upper body blood pressure with upper to lower extremity blood pressure difference more than 20 millimeters of mercury, radiofemoral delay, claudication, or evidence of a gradient across the coarctation by echocardiogram. These are 4 things that should make you suspect if there is restenosis or re-coarctation. Aneurysms of the aorta are not seen well by TTE, so aortic cross-sectional imaging should be done by MRI or CT angiography. MRI or CT angiography for post-repair monitoring of CoA should be done every 3 to 5 years in asymptomatic patients to monitor for re-coarctation of aneurysm formation. Lastly, I just want to briefly talk about interruption of the aortic arch before we finish this episode. There are 3 types of interruption of the aortic arch: type A, B, and C. Type A, which accounts for 13%, is disruption distal to the left subclavian arteries. So all main arteries coming off the arch have already been given off, so the main pulmonary artery ends up becoming the descending aorta. Type B, which occurs in 84% of patients who have interruption of aortic arch, is where the disruption is between the left carotid artery and the left subclavian artery. The main pulmonary artery gives off the left subclavian artery before becoming the descending aorta. Type C, which occurs in 3%, is disruption between the innominate artery and the left carotid artery. The main pulmonary artery gives off the left carotid artery and the left subclavian artery before becoming the descending aorta. So the sequence of interruptions is actually C to B to A. The 2018 congenital heart guidelines say 22q11 syndrome is associated with tetralogy of Fallot, truncus arteriosus, and interruption of the aortic arch. 50% of interruption of aortic arch has a 22q deletion, DeGeorge syndrome. 33% of truncus arteriosus will have DeGeorge syndrome. 16% of tetralogy of Fallot will have DeGeorge syndrome, and 20 to 40% of DeGeorge syndrome will have tetralogy of Fallot. Just to remind us, the catch-22 mnemonic for DeGeorge syndrome is cardiac abnormalities, especially tetralogy of Fallot and interruption of the aortic arch, abnormal facies, underdeveloped chin, low-set ears, wide-set eyes, narrow groove in the upper lip, thymic aplasia, cleft palate, hypocalcemia, and 22q11.2 deletion. That's all for coarctation of the aorta and interruption of the aortic arch.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.